I'm Dan Bausch, ASTMH President. Good to see everyone again. I hope you enjoyed the plenary sessions last night in the morning of programs. My pleasure and honor to open this symposium in honor of Alan J. McGill. And I won't take long, just a few welcoming words. You know, many here knew Alan and knew what he represented. Alan was ASTMH president. That's when I first started my interaction with him. This must have been, I think in terms of Ebola years. This was the time when Ebola in West Africa was really raging very strong and had many impacts on the society. You may remember that the meeting that year was in New Orleans, and there were lots of pushback about who could travel there, whether the meeting could take place at all, whether people could interact and different things, somewhat reminiscent of COVID, but a little bit of a different era. And it took incredible leadership and incredible guidance to get the symposia, get the society through that incredibly difficult time. None of you in the room probably, even if you were at the meeting, would have noticed that. You wouldn't noticed all the things that happened because Alan was so good, actually, at guiding through guiding the society through an incredibly challenging moment. And that was just a testament to his skills and his professionalism internally and externally. I remember also, in a little bit more of a relaxed time, attending a meeting on Capitol Hill with Alan, and we had a little bit of time afterwards. And so he decided to go and look at the Smithsonian and take in some of the art in Washington. And so we spent an afternoon doing that. And you know, I think of that time now, a much more relaxed setting, and just how diverse Alan was in terms of his interest and his skills. So professional, but so diverse as well. So lots to think about, and really what an admirable person he was. And so this is his legacy. This is what we have here, and science, strong scientists, and promoting that. We're very honored from the society to be able to do that. And it's really great to have Zoom with us here today. We know we had a mishap last night, so you couldn't make it with us last night, but no problem. Your achievements were duly noted and will be, again, duly noted today. So enjoy the symposium, and I'll pass the podium over to Michele. Thank you.
Welcome, everyone, to the Alan J. McGill Malaria Eradication Symposium, which honors the life and work of the ASTMH past president, Alan McGill. My name is Michele Spring, and I work at the U.S. Armed Forces Research Institute of Medical Sciences in Bangkok, Thailand. Dr. McGill spent more than 20 years as a U.S. Army medical officer researching malaria, leishmaniasis, among other infectious diseases, after which he became the malaria director at the Bill and Melinda Gates Foundation. His work and leadership on malaria eradication have brought us closer to envisioning a world free of malaria. Having this annual symposium at ASTMH gives us an opportunity to continue his conversations and his mission. This year, the symposium will take a big picture look at some of the limitations and challenges facing malaria elimination. We have talks on uncovering the pernicious problem of simian malaria, tackling vivax with a limited therapeutic arsenal, and implementing strategies of high burden, high impact to push falciparum faster, closer to zero. And all of these efforts will also have to anticipate and adjust to a changing climate. In addition to this symposium, Dr. McGill's legacy is honored by the McGill Fellowship Program. Each year, one early to middle stage investigator is selected as a McGill Fellow and provided support to conduct projects in tropical medicine and global health, with a particular focus on leadership development. I'd like to invite our 2022, 2021, and 2020 recipients to the stage to be formally recognized. Our 2022 recipient is Fitsum Tedesse from Ethiopia, and our 2021 oh, sorry, yes. Okay. Oh, Awa, hi. Our 2021 recipient is Teshoke, and our 2020 recipient is Awa Benate Dem. So yes, now that we're back in person again, it's a pleasure to have our fellows and meet them in person and get a chance to talk to them after the symposium if you have a chance. Just a few short thank yous before we move on. Thank you to the McGill Fellowship Committee. Thank you to the Symposium Committee. Working with this group of people from all around the world has been really inspiring to hear everyone's perspectives on malaria eradication. Thank you to Karen Gorleski and Rhonda Schultz for your support, and to the Bill and Melinda Gates Foundation, who are the co-organizers and co-chairs of this symposium. Philip Welkoff, my co-chair, could not be here today, so we're represented by Abigail Pratt from the Bill and Melinda Gates Foundation, and I will turn the podium over to her. Thank you.
It is so lovely to see all of you here today. It's just wonderful to be in person. My name is Abigail Pratt. I'm a senior program officer on the malaria team at the Bill and Melinda Gates Foundation. I'm not Philip Welkoff, and every year he confesses that this is truly his favorite session at ASTMH. And I think the only thing that could have kept him from being here with you all today is the fact that he's actually with Bill and Melinda presenting our strategy, so competing scheduling. But the purpose of that meeting is to really talk through how we are using the financing and how we're building off of Alan's tremendous legacy. I only had the pleasure of meeting Alan once in 2014. We were at a meeting in Myanmar together, and we actually sat next to each other over lunch. And whilst I'm certain we talked about malaria, as all of us have a tendency to do when you sit two malaria folks next to each other, what I really remember about that conversation is a discussion that we had about our families. He was a military man, I come from a military family, we moved a lot, we all had our requisite stint in Germany, and I'd actually quite recently lost my dad, and I recall very distinctly, even from many, many years ago, that he just sat and he listened, and he then talked about that very unique pride that fathers have in their daughters, and talked about how proud he was of his daughters. And I hope that in addition to all of his tremendous work that he did in the malaria space and the impact that he's had on all of us, we also remember daily his warmth and really just his willingness to listen. So thinking of Alan, I know that we are here to actually hear about those who are continuing his fantastic work. So without further ado, I would like to introduce our first speaker. We have Dr. Kimberly Fornace, who is a Sir Henry Dale Fellow at the University of Glasgow. She's also a Senior Research Fellow at the National University of Singapore, an Assistant Professor at London School of Hygiene and Tropical Medicine, and she'll be speaking to us about the impact of environmental change on infectious disease dynamics. So, the floor is yours.
All right, well, thanks very much for having me here today, and it's nice to see this issue highlighted. So I'm going to speak a bit about the emergence of zoonotic malaria in changing landscapes, but particularly thinking about how this poses a global threat to malaria elimination. We are quite used to thinking of malaria as a human disease, and one of the things we really need to start to understand is to conceptualize malaria as a zoonotic disease. So like most infectious diseases, malaria does have a zoonotic origin, but also quite critically, there are a number of different malaria species circulating in non-human primates, which frequently spill over into people. And this is a problem not just of one particular area in the world, but a problem globally. So we've seen diseases such as Plasmodium simium in South America and Plasmodium knowlesi in Southeast Asia. Also, one thing to really highlight is that many of these simian malaria species are also very closely related to the 4 malaria parasites, which cause the majority of human malaria burden. So there is this continued threat that new parasites will spill over into people, but also that non-human primates could become a reservoir for human malaria species. And of course, when we're looking for simian malaria species, the more effort you put into looking for these, the more you find. So this is a very nice analysis which was conducted by Christina Faust, just looking at the total number of Plasmodium species that have been identified. On the dotted line, this shows globally and human hosts. And then these colors show different regions, the non-human primate species that have been identified. So one thing to point out is there's still species that have been identified fairly recently. But as well, if we look at the global distribution of non-human primates, there are many non-human primate populations that have not been surveyed at all. So we have real critical data gaps where we don't know what malaria species are circulating in different wildlife populations. But really kind of focusing this down from global simian malaria to look at one example of how simian malaria poses a very critical threat to malaria elimination, I'm going to speak a bit about Plasmodium knowlesi in Southeast Asia, and particularly how this exemplifies some of these challenges. So for those of you who aren't familiar with Plasmodium knowlesi, this is a zoonotic malaria species, which is typically carried by long-tailed and pig-tailed macaques. Like all malaria, it's transmitted by Anopheles mosquitoes, and it can cause severe and fatal malaria in people. But really, kind of the urgency of Plasmodium knowlesi has been highlighted most recently by what's happening in Malaysia. So this graph shows the surveillance data from Malaysia from 2000 to 2018. So as we've seen a strong and really effective malaria elimination program to the point where indigenous non-zoonotic malaria cases have very dramatically decreased during this period, we've also seen this parallel increase in zoonotic human cases of Plasmodium knowlesi. So at this point, since 2018, there have been no non-indigenous, non-zoonotic malaria cases reported in Malaysia, but we have thousands of human malaria cases of Plasmodium knowlesi every year. And this has really triggered this reconsideration of what it means to eliminate malaria and how countries with this very high burden of zoonotic malaria can achieve malaria elimination. So one thing to highlight is, although this is very clearly an emerging disease, Plasmodium knowlesi is not a new disease. So it was first identified in macaques in the 1930s. There was no evidence that it was an important public health problem, although it was shown experimentally that it could infect people. And this changed in the 1960s, where there was one case of an American working in Malaysia who was infected with malaria. They did some rather extensive diagnostic tests to show that he was not infected by one of the typical malaria parasites, human malaria parasites, but this was in fact Plasmodium knowlesi. However, after this one single case of a documented natural human infection, there was no other evidence that Plasmodium knowlesi was a public health issue at all. And this really changed in 2004 when Balbir Singh and colleagues working in Malaysian Borneo identified that a large number of cases of human malaria had been misdiagnosed by microscopy, and these were in fact Plasmodium knowlesi cases. And this could only be shown using molecular methods. Since this point, this picture has really changed across Southeast Asia. So this map is certainly incomplete. This just shows the human Plasmodium knowlesi cases which have been reported in peer-reviewed literature, so not necessarily in surveillance data. But there have been cases reported across Southeast Asia and parts of South Asia. But even with this quite coarse data, it's very apparent that there's real spatial heterogeneities in risk. So Malaysia continually reports the highest number of Plasmodium knowlesi cases globally, and in particular, Borneo and the Malaysian state of Sabah are really the epicenter of where we're seeing human Plasmodium knowlesi cases. So trying to think about why what's causing this emergence of Plasmodium knowlesi, or what factors could lead to this increase. One of the things that's immediately apparent is Malaysia and some of these other locations, which are reporting very high rates of Plasmodium knowlesi, have some of the highest rates of deforestation during the past 2 decades. So certainly this is the case in Malaysian Borneo. And there's increasing evidence to link human Plasmodium knowlesi risk with land cover change. So some of these early studies of clinical cases reported that forest exposure in many of the cases that were detected at clinics in both Sabah and Sarawak in Malaysian Borneo. This subsequent study, a population-based case control study, identified both forest and plantation activities as increasing Plasmodium knowlesi risks in clinical cases. But more recently, very extensive community-based surveys have found both deforestation, forest fragmentation, and different agricultural practices are associated with increased risks of human Plasmodium knowlesi exposure and infection as measured by a number of different diagnostic methods. So thinking a bit about what's underlying this risk, or how deforestation and these changing landscapes are impacting Plasmodium knowlesi dynamics. Certainly we have impacts on wildlife populations, so we know that these land use changes and deforestation impact the abundance and the distribution of wildlife populations, as well as their proximity to people. Certainly there's impacts on vector ecology, so deforestation can either increase or decrease available breeding sites for many mosquito vectors, as well as contribute to wider factors that impact the ecological, these ecosystems which vectors exist in. And finally, we've consistently seen this association with occupational risks and people working in some of these landscapes. So we know this has very important impacts on human space use. So where people are going, what types of landscapes they're entering when they're outside, and how this impacts their overall infection risks, their immunity to knowlesi and other malarias, as well as their healthcare access and their access to malaria control interventions. So certainly a kind of core piece of this picture is thinking actually about these wildlife populations. So there have been a number of studies now using different methods to try and understand the home range and habitat preferences of these key wildlife hosts. Increasingly, what's notable to see is that this wildlife-human interface is much closer than we would expect. So these macaques and the wildlife that hosts Plasmodium knowlesi are very well adapted to human settlements. So we're existing in quite close proximity for many people. Many people encounter these animals on a daily basis in peri-domestic habitats. Of course, the question is not just where are macaques, but where are infected macaques, or where are the infected wildlife reservoirs? And this is obviously very challenging data to collect. But looking at the distribution of infected wildlife reservoirs, we recently conducted a systematic review, looking at surveys that tested non-human primates for Plasmodium knowlesi using molecular methods that were capable of identifying this specific species. So across Southeast Asia, we found 123 unique surveys of about 5,000 non-human primates, mostly sampling long-tailed macaques, some pigtailed macaques, and a few other macaque species, and one example of a leaf monkey. So there's clearly key gaps in wildlife that hasn't been surveyed or hasn't been sampled for Plasmodium knowlesi in this region. But even with this very coarse data, one of the things that's immediately apparent is there's significant spatial heterogeneities in the wildlife reservoir prevalence, and these really mirror some of the increases in the human burden that we're seeing. So for example, Borneo, which reports the highest number of human cases, also has some of the highest documented wildlife reservoir prevalence. We additionally find that there's a very strong association with Plasmodium knowlesi risk in non-human primates and forest fragmentation. And the highest prevalence is documented in long-tailed macaques, although more data is needed on some of these other species. Of course, to understand malaria, we really need to understand the vector ecology. Within this region, Plasmodium knowlesi is transmitted by the Anopheles leucospirus group of mosquitoes, and there's been more and more work done to incriminate different vectors and to understand their biting patterns and distribution. So this is an example of work that was done by Indra Vaethalam, looking at a number of different vectors of Plasmodium knowlesi. And really what's quite critical is from some of this analysis is that these are all outdoor biting mosquitoes, so they're biting outside the houses, and particularly they're biting in early evening times. So this is times when people are not inside, they're not sleeping under a bed net, and many of the malaria control measures that we have are not really designed to be effective outside during early evening times. There have also been a number of studies looking at the impact of land cover on these different vector species. So this is an example from Sabah looking at Anopheles balabacensis, but mirrors what we found in many other settings where we find very, very low vector abundances in primary intact old growth forest, but we find much, much higher biting rates of these vectors and distribution of these vectors in secondary forests, so more disturbed forest and forest edges, and a mix in different agricultural land types. Integrating all this data together is really quite critical to understand how landscape actually impacts risk. So again, an example from some of the work we've done in Malaysia, but where we've done very detailed land cover mapping using a number of different data sources. We've also looked at how we can understand human space use, so using GPS tracking and a number of different methods to understand the probability that a person is in a particular location in a particular time. Integrating some of this mosquito biting rate data to understand spatio-temporal patterns of vector biting rates relative to habitats and seasonality. And finally, looking at what the probability that these vectors will be exposed or infected with pathogens from infected wildlife. And so at least within this site, putting this all together shows that human Plasmodium knowlesi exposure is primarily happening by forest edges. So in these areas where these different populations overlap, so within the forest, but also quite close to quite close to houses, where humans, mosquitoes, and non-human primates are all living very close together. Of course, with Plasmodium knowlesi, there's always a question, is this just environmental change, or do these increases in cases actually reflect some sort of changing transmission pattern? So we know the primary mechanism of this malaria is spillover from wildlife, so macaques or other non-human primates who are infected, passing this infection to mosquito, and mosquito going on to infect a person. But it has been demonstrated experimentally, although only once, that it is possible for a person to become infectious, infect a mosquito, and this mosquito to go on to infect another person. At the moment, we've just completed some work looking at a systematic review of different evidence types, as well as conducting some mathematical modeling to examine the evidence that whether or not this is happening. And we've found no evidence of widespread zoonotic transmission based on this, but this certainly doesn't disprove that this is happening at all. So really, this is something we need to think about in terms of future surveillance. So how do we design surveillance systems that are capable of not just detecting where these infections are occurring, but actually if there's any sorts of changes to transmission patterns. So kind of finally, thinking about simian malaria as a threat to global malaria elimination, I think it can be quite easy to dismiss this as something that's happening in a very isolated population in only one part of the world. But this is certainly not the case, and this does pose a threat to global malaria elimination. So in particular, we have unprecedented levels of environmental change globally, and this is changing these disease dynamics in ways that are difficult to predict. We also have, as we're increasingly eliminating other malaria species, changing levels of human immunity that may impact people's risks and exposure to and the impacts of these simian malaria parasites. One thing to highlight as well is at the moment we have no current control measures to stop spillover from wildlife reservoirs. So there has been some work that's been done looking at limiting exposure to outdoor biting mosquitoes. However, and trying to target specific risk populations based on occupational activities. However, this does not actually eliminate risk. So many of the interventions that we use from malaria to control the infectious reservoir are not necessarily feasible or appropriate when we have this wildlife reservoir. So certainly, I think there's a really urgent need to think about innovative surveillance and control strategies to think about how we can mitigate these future risks and also how we can detect them better. I think to end on a much more positive note, one of the things we've seen is that we increasingly have more and more data to try and understand these changing environmental factors. So for example, we have sources of Earth observation data, such as from drones and satellite data, where we can actually map some of these changes as they occur in near real time. So we have the opportunity to think about not just how do we target surveillance measures, but also starting to think more and more about how do we identify sustainable ways of managing landscapes that reduce human health risks. So with that, I'd like to thank everyone who was involved in this work, and thank you very much.
So our next speaker is Professor Dennis Shanks. He's the director of the Australian Defence Force Malaria and Infectious Disease Institute in Brisbane, Australia. He's a retired U.S. Army medical officer who helped develop both atovaquone buranol and Phenoquin as anti-malarial drugs. He's now working on the epidemiology of malaria elimination.
Where's the mouse? There's no mouse.
There is no mouse.
All right, there we go.
Hold on.
Okay.
Now we just need to make it big.
Okay. Good afternoon. I'm very pleased and honored to be giving a part of the symposium in honor of my good friend, Alan McGill. And today we'd like to talk about accelerating malaria elimination using a difficult class of drugs called 8-aminoquinolines. Now, nothing against our high-burden countries, but where you eliminate malaria, get rid of it entirely, has to be on the margins of transmission. Now, that can be in Africa, but predominantly we're talking about residual transmission areas in Latin America and parts of Asia and Oceania. Increasingly, what we're talking about in these sorts of places is relapsing malaria, particularly Plasmodium vivax. The only drugs we have that kill gametocytes, meaning they block transmission, and also kill the hypnozoite, meaning they stop relapses, are the 8-aminoquinolines. And I would suggest to you that we need to learn better how to use them. Now, as we all know, COVID has disrupted everyone, and that's certainly true with the field of malaria also. There have been very few travelers, and the health system has taken an enormous knock. There are apparently fairly optimistic numbers out of parts of Southeast Asia and Oceania. I would caution against taking too much stock of them. Again, everyone's been busy with COVID. Malaria programs have been neglected. Some of the counts look good because they haven't been able to do them. We're uncertain if these apparent downward trends will be reversed as travelers start coming back and as the health system begins to catch its breath. But don't think that malaria just goes away. It doesn't. Admittedly, 8-aminoquinolines are problematic medications. Right now, we have two that we can use routinely. Phenoquin is an 80-year-old drug. It's given over 1 to 2 weeks with chloroquine, and it cures vivax. In low doses, it also kills gametocytes. Phenoquin. I seem to have spent most of my career developing Phenoquin, and I would love to tell you that it's a magnificent breakthrough. In reality, it's a much better Phenoquin. You can give it at higher doses, it's less reactogenic, it works. But think of it a lot like a long-acting Phenoquin. In a single dose with chloroquine, you can cure relapses. You can cure vivax malaria. It's also registered for chemoprophylaxis and has other aspects that we'll talk about. These are the only drugs we have that will cure relapsing malaria. And frankly, whatever's in the pipeline, it's too far out to really make a difference for malaria elimination, certainly now and maybe even for the next generation. So we really need to learn how to use these problematic medications. The key to understanding their action is understanding their metabolism, which has taken us quite a while, because the really active part is a redox active intermediate that's there and gone very, very quickly. We see, particularly in the urine, a stable metabolite called 5,6-orthoquinone, and those you can measure. But if you don't create a redox active intermediate with your 8-aminoquinoline, it doesn't work. For Phenoquin, this means you need some activity in your cytochrome 2d6. There's much less of a requirement for Phenoquin, which probably utilizes other cytochromes too. But you have to generate a redox stress to kill the parasite. You're balanced on a knife edge. You've got to kill or inactivate the parasite without starting a massive hemolytic reaction. It's a balance, but it's a balance we're learning to do better with and we need to improve on. Phenoquin. Now, it's very similar to Primaquin, but it starts off with a preliminary step. There's a blocking group on the 5 position, a trifluorotoluene. And until you get rid of that group, nothing much happens. It's a beautiful, stable, long-acting drug, but you have to generate a redox-active intermediate. Once that group goes, usually by non-enzymatic means, then, frankly, it looks pretty much like Primaquin, and you get a 5,6 orthoquinone that usually shows up in the urine. I invite you to see poster 902 from Jeff Burrell tomorrow on much more details on the pharmacology. With the permission of Michele Spring, I'd like to show you some interesting monkey malaria urine data. And it explains something that we've really not understood in relapsing malaria for quite some time. Why do drugs such as chloroquine and quinine that have no effect on the hypnozoite work much, much better when you put them with an 8-aminoquinoline? Well, it drives the 8-aminoquinoline metabolism. And granted, this is a small number of monkeys, and it is in urine, but it really tells you that the important thing is a redox stress on the parasite, in this case, the primate. We know from other studies that this is very important, and you get a log extra in terms of efficacy simply by combining your Phenoquin with chloroquine. What's the problem? Well, the problem is that glucose 6-phosphate dehydrogenase deficiency is a fairly common human polymorphism. And if you get it wrong, as I did in this picture in a Phenoquin study, you can hemolyze your patient. This is urine, not blood. Now, this came about not because I didn't know to test G6PD deficiency, but because of a clerical error. This happens in all clinical studies that are trying very hard to avoid this. This is an N of 1. It's the only severe hemolytic reaction we've ever had with the Phenoquin. And I show it not to convince you that this is a dangerous drug. It's not. But it is a hemolytic drug if you give it to someone who has G6PD deficiency. Note that it was 1.2 grams that we gave, that the person didn't hemolyze until the 3rd day. Now, that's still no excuse. You don't want this to happen. But I suggest to you that the way we're going to avoid this is not doing perfect G6PD screening on everyone. That's impossible, particularly out in the periphery where it's needed. But we're going to have to find a dosage of a potentially hemolytic drug that will not cause severe reactions like this. Is this possible? Can we balance safety and efficacy with 8-aminoquinolines? Well, I think we can. Right now, you can give 15 milligrams of Primaquin with WHO's blessing without testing anybody for G6PD deficiency. For well over 50 years, the US Army gave 45 milligrams in a chloroquine Primaquin tablet to soldiers without testing anybody. And although there were hemolytic reactions in soldiers, we gave it to CP tablets to over 2 million soldiers during the Vietnam War, and there was not a single death, not one. What about 100 milligrams of Phenoquin? Well, that's been shown in G6PD deficient people, and the reference is there, that is not a hemolytic dose. What you see pictured from Rosemary Rockford's group in Colorado is that when you take human G6PD deficient cells and put them into a humanized mice, that yes, indeed, both Primaquin and Phenoquin hemolyze the cells. Phenoquin does it much more slowly because, again, you generate a redox active intermediate, but there's a prior step that makes it a slower process, less likely to generate a severe hemolytic reaction. Why do we need this? Well, we need it to block transmission. The gametocytes are intrinsically vulnerable to redox action. I think it's probably because they have to retain the malaria pigment. And the malaria pigment is still redox active on its surface, this hemozoin. And the drugs that promote this inactivate the gametocyte. Now, you don't have to use an 8-aminoequivalent. You can use a redox cycler like methylene blue, and this effectively kills gametocytes. It's a very good gametocide. And when you put it with the Phenoquin, it's even better. We wish that one of our students had come to present this data, but I can tell you with some confidence that if you combine Phenoquin and methylene blue, it kills VF gametocytes, both mature and immature, synergistically in vitro, and needs more work, but it certainly works. How about in people? How about inactivating gametocytes in people? Well, yes, it does. Bridget Barber and our group has tested this in a human falciparum challenge model in Brisbane, and the CID paper and graph is shown there. Chris Drakeley's group at the London School have done the study in Mali, and I invite you to come hear their abstract 593 in a later session, and they can describe that. These are really very low doses. This is 50 milligrams to inactivate gametocytes. Again, it's slower than the faster acting Primaquin, but it still works, and it can still be used to block transmission. 2 years ago at this conference, Kevin Baird presented the frankly disappointing data from the Inspector trial of Indonesian soldiers, where they showed that DHA piperacin combined with the Phenoquin did not cure people who had 5-AX malaria. This has been a very dark cloud over the drug, and it's being explained at this conference and other places. But it's basically the artemisinin component. And as much as we would operationally like to use an ACT plus Phenoquin, that's probably not possible. They're antagonistic. Chloroquine is synergistic, as I showed you with the monkey data earlier, and works well together. Methylene blue, as shown in the picture, forms a very nice isobologram, data going back to Dennis Kyle over 20 years ago, and I would invite you to see poster 227 from Marina Chavcic for a lot more data than just this simple isobologram. But methylene blue and Phenoquin work very well together. What about the Hypnozoite? Well, nobody really understands the Hypnozoite, but you seem to have to trigger hemolysis or redox action to either inactivate or either activate and then kill or inactivate the latent parasite in the liver. Walter Reed, specifically Alison Roth, has studied this using her fine in vitro model with Peace and Emulgi, and really suggests that if you combine artemisinines with Phenoquin, it's antagonistic against hypnozoites, and when you combine it with methylene blue, it's very significantly synergistic. Again, I invite you to attend the later session and hear from Alison herself about her data. But it's consistent in terms of methylene blue being synergistic with Phenoquin. Why is this important? Well, I think the harm of relapsing malaria, particularly 5-AX, is very underrated. When you look at mortality statistics, particularly when you do eliminate an area, it appears that malaria-associated or indirect mortality is at least as large as the direct component that we know about that's killing people. This may possibly be due to hidden biomass, particularly in Duffy-negative people, where the parasite hides in the deep tissues, such as the spleen and the bone marrow. This disruption of the RES may cause immune deficits and a higher mortality rate from infections that we would not normally associate with malaria. A lot still to be worked out, but don't underrate 5-AX orovale malaria. It kills people. Can you eliminate malaria at a countrywide basis using mass drug and 8-aminoequivalents? Yes, it's been done. Now, I doubt there are many people in the room that worked in the former Soviet Union, or even less in North Korea, but it has been done. And it can be done if we're not afraid of using these drugs, which we've had for quite some time. More recently, the Chinese have studied it on some islands and in focal mass drug administration in their elimination from their entire country of China. I say that there should be a low dose of Phenoquin in combination that can be adapted for mass drug administration. So, channeling Alan McGill, shown here trying to look beyond the lighthouse as to where we should be going, I suggest that there are 3 things we need to think about with 8 aminoquinolines and malaria elimination. We need to determine a post-exposure Phenoquin combination that will stop most late relapses. We need to determine if Phenoquin plus methylene blue will block transmission for up to a month. And we need to find a low-dose Phenoquin drug combination that can be given without G6PD screening. Why? Well, I think we need a 3rd indication for Phenoquin. We have an established with chloroquine treatment regimen. We have an established prophylaxis regimen, and you can give it for up to a year on a weekly basis. What we need is something that will actually turn off malaria transmission and allow us to bend the curve downwards and eliminate malaria. You see the triple drug combination that I am suggesting. Before you say that it can't possibly work, let me suggest you might want to talk to your filarial colleagues. They took 3 old drugs, ivermectin, iobendazole, and the supposedly toxic DEC, and are doing great things with it in terms of elimination of even adult worms. I think we need to think like an NTD. We need to block transmission for a month, clear residual blood parasites, and kill most hypnozoites. Can you do that in a single dose? Maybe not. Maybe you have to give it for a month, and then another month, and then another month, and 3 doses total. Then it begins to look more like seasonal malaria chemoprevention, and that has been shown to be quite possible too. We need to find something that won't trigger massive hemolytic reactions in G6PD deficient people. No, we're not going to get to the GSK standard of 000 hemolysis, but I don't think we want to. We're still looking for an efficacious drug. And it needs to be tested in mobile populations or on small islands to show that we can get the public health effect we want. We have to use 8 aminoquinolines if we're going to eliminate malaria. We can't act like relapsing malaria isn't out there because they have a real survival advantage. They will be the last parasites standing. The only drugs we have which will both stop transmission and relapse are 8 aminoquinolines. And there is a low dose of Perpetua, which we can use in G6PD deficient people. And by following the same logic, there is also a safe dose of Phenoquin. We need to find out what it is. And mass drug administration for malaria elimination has worked in the past, worked well, and we need to employ it in the future to accelerate malaria elimination, particularly in places where we're predominantly dealing with vivax, such as the Americas and Asia. I thank you for your attention and want to note the many institutions we work with. I've tried to cite particular individuals as we've gone along. If I missed anyone, I apologize. This was certainly a group effort. Thank you.
Thank you very much, Professor Shanks. I would like to welcome Dr. Perpetua UhomoibhI to the podium. Dr. Perpetua is the Director and National Coordinator at the National Malaria Elimination Program in Nigeria. With over 20 years experience in public health, Dr. Perpetua oversees and coordinates all of the malaria programming of partners and government at the subnational and national levels in Nigeria, with a focus on research, monitoring, and evaluation. And she will be speaking to us about the High Burden, High Impact Initiative in Nigeria.
Thank you.
There we go. You should be. Perfect. Over to you.
Okay. Good afternoon, everyone. This is the, okay, what's the presentation mode? Okay. This is the topic of my presentation, the road to malaria elimination, experiences, limitations, and challenges of the high burden, high impact approach in Nigeria. And that's the outline. As a background, we know that globally, we have seen an upward trend in malaria cases, particularly since 2015, more so in Nigeria. And we have also witnessed similar downward trend in the last 20 years in malaria deaths globally, also in Nigeria. But from about 2017, we have seen an upward trend, particularly after the COVID pandemic. And so what we are witnessing is that about 241 million cases of malaria was recorded globally in the last World Malaria Report, of which Nigeria contributed 27%. And deaths, Nigeria also contributed 32%. That's about a third of the global malaria deaths. So basically, the world is off track in meeting the global technical strategy targets, particularly in a reduction in cases and deaths by at least 40% by 2020. When we look at these statistics, it doesn't mean that we are not having some successes. So in terms of the total number of cases and deaths averted between 2000 and 2019, the last 20 years, we've seen that globally, the world has witnessed about 1.5 billion malaria cases averted and about 7.6 million deaths averted in the last 20 years. And 2% of the cases occurred in the WHO African region, and 94% of deaths averted also in the African region. Now, when you look at similar trend in Nigeria, we've seen that about 228 million cases have been averted, which is about 30% of the global cases have been averted in the last 20 years, and about 2.6 million deaths, which correspond to about 25%, a quarter of the global deaths averted. Of course, this is due to the massive investments that have been put in the globally in malaria implementation since the beginning of the millennium. Now,
you're doing perfectly. They're seeing that one, so it's just one step behind. So when you want to speak to that one, just advance it.
Okay. Okay. Yeah. All right. So, all right. Thank you. Okay. So, I think I've spoken to that already. When we come to the high burden, high impact, so despite these cases and deaths that have been averted, there has been a stall in progress since 2015, like I mentioned earlier, and so we are off track from the global technical strategy targets. Therefore, the need to have an expanded strategy globally. And about 11 countries, 10 in the African region plus India, account for about 70% of the global burden. Of these, the four countries that are mostly responsible for the highest number of deaths and cases are Nigeria, of course, like I mentioned earlier. In terms of cases, about 27%, and followed by the Democratic Republic of Congo, Tanzania, Uganda. Similarly, the same countries account for the highest number of deaths globally. Now, the high burden, high impact approach is a targeted malaria response because, of course, WHO and the RBM partnership came up with this approach to ensure that countries who have been recording that have not been able to meet their global technical strategy targets and milestones we have to look for a new way of approaching malaria implementation. And so they launched the HVHI approach in 2018 to accelerate progress against malaria towards attaining the GTS milestones and goals. The high burden, high impact approach is a country-led, country-driven approach, which is focused on improving public health response in achieving reduction in malaria cases and deaths in the 11 highest burden countries, namely Burkina Faso, Cameroon, DRC, Ghana, Mali, Mozambique, Niger, Nigeria, Uganda, and Tanzania and India. That's alphabetically. I mentioned this. Basically, am I going back? Oh, sorry. Okay, sure. Okay. Now, what is the guiding principle of the high burden, high impact approach? So firstly, it's a country-owned, country-led approach that aligns with countries' sustainable development goals, national strategic health development plans, and the national malaria strategic plans. And it ensures a better coordinated response and support from partners and funders to meet countries' needs and fill programmatic gaps. Also ensures commitment from partners to support countries in the generation and availability of data for analysis and use for decision-making. It also supports increased domestic and international resource mobilization for malaria. Now, the high burden, high impact approach builds on a very strong and effective health system and a multi-sectoral response. And it has 4 mutually reinforcing response elements that, when implemented, it will feed into tangible actions through National Malaria Strategic Plan implementation and concrete outcomes. What are these 4 response elements? First is political will to reduce malaria deaths, strategic information to drive impact, better guidance, policies, and strategies, and a coordinated national malaria response. Now, when it comes to the Nigerian experience on the high burden, high impact, Nigeria launched the high burden, high impact approach shortly after the WHO and the RBM partnership launched it in 2018. So we launched it in 2019. And immediately when we had a national dialogue with our RBM partners, supported by the WHO, and we immediately constituted the thematic committees and work groups that will work along the 4 response elements. And luckily for us, we were just at the end, we were almost at the end of a strategic plan at the time, so it was easy for us to use this approach to conduct a malaria program review and develop the new strategic plan, which we are currently implementing from 2021 to 2025. And we also use these 4 response elements to develop our annual work plan using data from the stratification and sub-national tailoring that was done. So immediately, with the support of WHO, we had an appraisal, a baseline appraisal, and using the tools that we had, and to know where we are currently, where we are off track, and where the gaps are, and what we can do within the strategic plan we were about to develop. And since then, we have been conducting quarterly assessments of the implementation status of this high burden, high impact Nigeria, and where we are, of course, with WHO and ALMA providing oversight on what we are doing. Now, what are some of the benefits of the high burden to high impact approach? So the self-appraisal tool that we were provided with guidance from WHO helped us in analyzing the current situation with malaria programming. And the tool also brought about better appreciation of the interlinkages between the different response elements, as well as formulating indicators that we track quarterly. And Also, the country has strengthened ownership of the malaria program with improved prioritization of malaria. And the need for good quality data and associated challenges were better appreciated with an overall improvement in data use. And of course, WHO and the RBM partners have also helped us, the country, due to the clarity of needs and improved focus of activities. So it gave us a new impetus in the malaria program implementation in Nigeria. When we look closely at each of those response elements, first of all, we want to look at the political will. So what has the country done so far? We've established the End Malaria Council at the highest level. It was launched by the president of the country in the third quarter of this year. And we have also strengthened advocacy visits to the states to provide more funding for malaria program implementation, particularly the NET campaigns and the seasonal malaria chemoprevention campaigns. So they are putting more budgetary allocation to malaria implementation to complement what our funding partners are doing for us. And we also have strengthened advocacy visits to private sector organizations, multinational organizations, NGOs, and other foundations to play more role by supporting malaria funding, financing, and in-kind support for malaria implementation in Nigeria. And currently, we've also made advocacy visit to the National Assembly, who are the ones that approve the budget for malaria for the government. And there's a push for malaria agenda underway at the National Assembly. In terms of the awareness creation, we've also developed different strategies, such as the new SBC strategy, using the stratification of the communication at all levels, and also using different multimedia platforms to push the malaria message to the populace. And the other area we have also worked on, of course, this was when we launched the End Malaria Council. By the way, the End Malaria Council, the chairman of that council is Alhaji Dangote, who is also a global malaria ambassador and sits at the board of the Global End Malaria Council. Nigeria was one of the first countries to establish the National Malaria Data Repository. I'm looking at the strategic information use. And that malaria data repository has been operational since 2020. And it has enhanced availability of routine and non-routine malaria data under one platform. And it's also, we also use it for data quality issues within. So the routine data, we sync it directly from the National District Health Information System, while the non-routine data, we collect it, such as the campaign data, the seasonal malaria chemoprevention implementation data, that's the non-routine data. So it makes all these data available within one database for ease of use for decision making. And also we also track implementation and engaging with the Governors Forum to make sure that we use the scorecard for them to see how their states are faring in terms of bringing down the burden of malaria in the country. So beyond that, for the second response element, we've also done situational analysis and progress reviews. For the subnational tailoring and certification that we did for the strategic plan, we collected data at least for the last 10 years to see where data such as routine data, malaria incidents from health facilities, data from surveys, national surveys, entomological data from our sentinel sites, including insecticide-resistant monitoring data, therapeutic efficacy data. So we brought all those data together up to the local government or district level. And with that data, we were able to do modeling, looking at different scenarios for what we can impact. That helped us to set targets for our current strategic plan. Looking at different scenarios, assuming we optimize all our interventions at 80%, where will we be by 2025? Or if we were only able to have coverage of 30%, where will it take us to by 2025, and so on. So we consider different scenarios, and with this modeling from the Northwestern University, we were able to show what we will achieve by 2025, and that is some of the picture you are seeing. And with that, we develop package of interventions at each district level, the local government level, using different interventions that will make impact based on these different data that we had collected, ecological data, rainfall seasonality pattern data, and all that. So with that, we were able to scale up seasonal malaria chemo prevention from the initial 9 states in the country, in the Sahelian region, which were, out of 36 states plus the Federal Capital Territory, to 21 states. And so since 2020, we are now implementing seasonal malaria chemo prevention in about 2/3 of the country based on this stratification and modeling, impact modeling that was done. And so we have also been able to target interventions, because we know that some of those interventions, such as case management, for instance, we have to do that nationally, but interventions such as seasonal malaria chemo prevention, based on the data, is in about 2/3 of the country. Then ITN, and for the ITN deployment, what we have also done is to use the data that we get from our insecticide resistant monitoring site to determine what kind of nets, because we are seeing increasing level of resistance to pyrethroid-only nets. And so we were able to use those data from the insecticide resistant monitoring sites to determine what kind of nets that's suitable for each state in the country, because we do like a rolling campaign where some states are due for mass net distribution every 3 years. So based on those data, we determine whether it's PBO, and of course the kind of resistant pattern that is there, whether it's metabolic or not. Then we determine whether a state would benefit from just pyrethroid-only nets, or PBO nets, or even the dual active ingredients nets. So we're using all these data. Of course, all this is from the certification that we did and the HBHI approach that we adopted in the country. In terms of, in terms of other things like monitoring and evaluation, we have strengthened that across the country. We do a lot of coordination meetings, subnational data quality audit visits, supportive supervision, and others as often as we need to do. We are on the third response element, which is guidance, availability of guidance, policies, and strategies. We have updated most of our malaria documents, such as the strategic plan, the monitoring and evaluation plan, training manuals, the SBC strategy, and others. They are all updated, and we're using them both at the national level and the sub-national level. Then we've also done a lot of, the clear guidelines are now available, like I said, for implementation. And we have meetings, annual meetings with the state malaria programs to ensure that they are aligning with the strategic plan at the national level, and also having opportunities to share experience and best practices with other states as well. On the coordination, so some of this coordination, we have a very strong coordination platform at the national level, and we're encouraging states to have the same for exchange of ideas and ensure efficiency in implementation. And in terms of private sector engagement, we've also developed a private sector engagement strategy to ensure that there's more support from the private sector. And what we also did in terms of the political will was to do a partners mapping for the coordination, and so that we can align partner support with specific states. So with that, we had about 1/3 of the country that didn't have any major partner funding. And with that in mind, we had to approach the bank, the World Bank and Islamic Bank, to get a loan facility to cover about $300 million to cover that the third of the country that had no major partner funding. With that, we have full coverage across the country to ensure that everyone is at the same level of implementation for us to be able to achieve impact. And we have also done a lot of alignment of partner support. I've done that, such as for different interventions, we know exactly what a partner is funding, and then where there are gaps that we can approach other donors or the private sector, as the case may be. And we are also having these regular review meetings with the RBM and the ALMA to ensure that where there are gaps, we are able to meet them, whether it's commodity gap or technical assistance that is needed to ensure that we fill those gaps. So we have a very robust strategic plan, well costed, that we are currently implementing. In terms of achievements, I've mentioned some of them. For seasonal malaria chemo prevention, in the last 2 years, we've seen it increase for about 13 million targeted children that were reached with the SPAQ to about 27 million as at this year, end of the SMC cycle this year, across these 21 states. In the ITN campaigns, we've distributed about over 17 million nets in 2021 and 28 million nets this year alone. And the country has procured over 13 million RDT for about 13 states of the country that's supported with the Global Fund, and also over 12 million ACTs distributed in those states of the country. We have also procured a lot of injection artesunate, and also the country has also started procuring sulfadoxine pyrimethamine for IPTP, although we have some gap there because we are experiencing some stockouts due to some regulations from the government that ban the use of SP importation in the country. So we have had to look inward to see how we can bridge that gap to ensure that we expedite WHO pre-qualification for the local pharmaceutical industry to be able to provide us with the SP need for the malaria program. Similarly, across the other thematic areas of our program, we have seen improvement in our implementation and ensured efficiency. One thing I would like to mention is that we have increasingly adopted use of digital technology for our campaigns, in particular, using digital technology for the ITN implementation and the seasonal malaria chemo implementation. So it has really helped us to improve in our efficiencies in our program, particularly with issues such as tracking implementation. You see the real-time data where the distributions are taking place, and issues about payments that used to delay payments, we've addressed those, so there is more efficiency and cost saving in use of technology in campaign implementation. Even now we are expanding it to routine activities such as data quality audits, supporting supervisory visits, and other routine activities to improve our program implementation. What are some of the challenges we have experienced in adopting the HBHI approach? We have done some, although we have largely had a lot of success at the national level, not so much at the sub-national level. There's still some, not so much clarity about what the HBHI is about. And so we are planning to improve our support, technical support to the sub-national level to ensure that they fully understand the HBHI approach and how they can better use it in program implementation. The private sector engagement has not been too successful, but we are trying to scale that up to ensure that there's more private sector involvement to meet the funding gap and in-kind support for the malaria program in the country. And there's some funding gap, obviously, to fully implement this package of interventions that we had developed from the stratification and impact modeling that was done, and particularly, of course, with the global downturn in the economy, that also affected our malaria program implementation. So we still have some funding gap. And there are some limitations related to existing structure of the NMEP and the state malaria program, like I said, which is affecting implementation at the operational level. And there are also challenges initially trying to understand the elements in the HBHI approach as they related to some of the key areas, such as political will. And, but we have been able to address some of those. In terms of recommendations, what are we recommending on the HBHI approach, particularly for countries, the high-body countries who have not yet adopted this approach, is to ensure that at the beginning you have a very robust in-country dialogue with all the relevant stakeholders to ensure buy-in, and also with the partners to ensure buy-in into the high-body and high-impact, and ensure that you have guiding documents for clarity of purpose when you go into the implementation. And we also solicit more partners' support for our implementation, particularly in the area of data, and to ensure that we have more quality data, because that has continued to be a challenge for the country. So we also solicit support from funders as well to bridge some of the funding gap. But we also recommend that HBHI should continue to be supported in countries and align with malaria strategic plan for more efficient implementation of the program, malaria program, because it's really the way to go. It helps you to better put things in perspective and focus, so you have a clear direction on where you want to go, especially when you are setting your targets in your strategic plan, and you are able to better define your implementation along those response elements, which really provide a clear direction for you to go. So that is basically it. In conclusion, I would like to say that the HBHI approach has helped the country to refocus, particularly for us in Nigeria, to better target strategies that would accelerate reduction of malaria cases and deaths, to bring the countries back on track to attaining the global technical strategy milestones, and also to galvanize stronger political will, that galvanizing stronger political will is essential to bridging the gap in successful implementation of the HBHI approach. Like I mentioned earlier, you have to have a buy-in, country buy-in and partners buy-in. And there's a need for more support from global partners in resource mobilization and investments in malaria control and technical support from partners as well. And subnational micro-stratification and tailoring of intervention mixes and subnational buy-in and ownership is critical to achieving success and impact on return on investments. And lastly, our partners support, both financial and technical, that will better align to countries' strategic plans and needs. And guidance from country, in a way, is the best way to go to achieve the HBHI strategy. Thank you.
Thank you. We're at our last speaker, Dr. Peter Gething. Dr. Gething is a John Curtin Distinguished Professor in Epidemiology at Telethon Kids Institute and Curtin University in Perth, Australia. Professor Gething leads the Malaria Atlas Project, an international collaboration that develops geospatial analytics to track malaria burden and support effective control planning. While we're setting up, we'll have a Q&A after Dr. Gething speaks, and we only have one microphone over here to the left, and if this side, I can always bring a microphone out to you if you want to ask your questions. Thank you.
Thank you. Good afternoon, everybody. I too am very pleased and very honoured to be part of this very special session, honouring the work and the ongoing legacy of Alan McGill. So I've been asked to talk about, or to address the question of what climate change will mean for malaria elimination. And I feel I need to start this talk with some expectation management. I don't think I'm going to come in with a very simple and clear answer to this question. But I would also challenge anyone who says that there is a clear answer to this question. If we start with what we do know, so what are the mechanisms by which climate does mediate malaria transmission? If we start with the most simple aspect of climate in that regard, which is temperature. So we do know that the lifespan of Anopheles mosquitoes is strongly mediated by ambient temperature. And we also know that the rate at which they bite and take blood meals is also strongly affected by temperature. We know, of course, that the parasite has to undergo sporogony, so that's the extrinsic incubation period inside the mosquito midgut. That too, the duration of that period is strongly affected by the ambient temperature. And so if we put these relationships together, we come up with a kind of temperature suitability curve, a dependency curve, which highlights the range of temperatures at which malaria transmission is going to be more intense. And as you move out of that optimum range, the suitability for transmission rapidly diminishes. And we can take that relationship and we can combine it with detailed ground data on air temperature, and we can map out the relative influence of temperature on generating suitable conditions for malaria transmission. So what about rainfall? Now, of course, we know Anopheles, like all mosquitoes, require aquatic habitats in which to oviposit and for their larvae to develop. And of course, we know we need rain to generate aquatic habitats. But the relationship between how much rain falls out of the sky and how suitable the environment will be for malaria is a very complex one. And that relationship is something we only partially understand and are only partially able to quantify. And there's a few reasons for that complexity. One is that the type of aquatic habitat that Anopheles prefer to oviposit in varies dramatically between species. So it varies from large permanent water bodies for some species, and for others it's very small transitory water bodies that could be formed, for example, just from a single hoof print and with a rain shower in that hoof print. And then, of course, the relationship between the rain falling and the habitat forming is dictated by the local hydrology and the nature of the soils and the rocks and the topography and the local drainage system. So again, that's another complex system that's very, very locally specific. And so the complexity here means that the science is unresolved in terms of the relationship between rainfall and malaria transmission. There's a lot that we still don't understand and are not able to accurately quantify. And so there's been a whole range of studies that have attempted to capture this relationship. One common approach is to attempt to define a threshold, so a minimum amount of rainfall that's required in a given time period in order to enable malaria transmission to occur. But as you can see from these comparisons, there's not much consensus about what that threshold actually is, and different choices of threshold yield very different maps of suitability. Perhaps a slightly more sophisticated approach is to couple models that better represent the hydrology, so actual mechanistic hydrological models with malaria transmission models, and they come out with yet another representation of this relationship between rainfall and transmission. Okay, so we don't know everything about these mechanisms, but we certainly are sure that both rainfall and temperature strongly mediate the suitability for malaria transmission. So how are those factors forecast and projected to change in a future warming world? So you'll all be broadly familiar with the basic climate science around this. The IPCC don't attempt to have one single projection of what the future climate in this world will look like, but they base their projections around scenarios. So there's 5 key scenarios called the shared socioeconomic pathways, which represent very different trajectories that the world and humanity is potentially on in the next 100 years. They differ in all sorts of different ways, but the main driver of difference is the amount of CO2 that humanity is going to release into the atmosphere this century. And then there's an equivalent set of climate projections that go with each one of those 5 scenarios. So in all but the most optimistic scenarios, you can see that both temperature and rainfall are projected to increase quite dramatically throughout the duration of this century. Important to also note, though, that those global average trends have quite different manifestations in different regions. So for temperature, the simple manifestation of that is that the higher latitudes you move to, so as you go closer to the poles, the proportional increase in temperature is greater. And for rainfall, it's a more complex picture. It's a more of a mixed bag. So although average trends are for increasing precipitation, there are significant parts of the world where actually climate change will mean they become drier rather than wetter in the long term. So what then do those projected trends mean for malaria? And there's been numerous studies that have attempted to answer this question over recent years, generally by taking those climate projections and linking them with different types of models of malaria transmission, whether they're empirical models or mechanistic models. But the results are highly variable, and there's by no means a sort of unified consensus about what these global trends in climate will translate into in terms of trends in malaria. That variability in the conclusions stems from lots of different places. Of course, the choice of scenario that's being looked at will have a big influence. But really it reflects the lack of certainty, the lack of consensus in the science around these relationships between rainfall, temperature, and malaria. So there's no kind of very clear picture that emerges. But there are some commonalities that I can briefly highlight. So this is just one example of a study that attempts to predict changing trends in malaria as a function of climate change. Recent work by Smith et al., published in Nature Communications. So the map shows projected changes in suitability for malaria transmission towards the end of this century. Essentially, the red and oranges are places that are projected to become more suitable for malaria transmission, and then the blue shades are places that are projected to become less suitable. So there's some patterns in this particular projection that we see again and again in other work. There's particular consensus around areas that are currently limited by being too cool, or they have a relatively small amount of malaria because they're at the lower end of the suitability range for temperature. So of course, as those places get warmer, they all move into that zone of more suitability. So in Africa, this would include the East African highland areas. So you can see the Ethiopian highlands there standing out very clearly, and all the way through that kind of Rift Valley system down through Kenya and Uganda and Tanzania. Those higher altitude locations where suitability is very, very likely to increase in a warmer world. And then for similar reasons, if you look to the southern range of malaria down in South Africa, again, that warming trend shifts southwards that boundary of suitability. Interestingly, this particular projection also includes suitability in Lesotho, which is a country that currently doesn't have any malaria because of its cool temperatures and its high altitude. So those patterns, there's a degree of confidence in those particular predictions. But if you look elsewhere on the continent, you see a lot of blue and a lot of orange. You see a lot of variation, places that potentially would get more malaria and places that will get less. And that really reflects places where the limiting factor is more to do with rainfall than it is to do with temperature. And we're just far less certain, both about the relationship between rainfall and malaria, and the climate predictions themselves for rainfall are just a lot more variable and a lot more complex. Okay, so that's kind of a little bit of a big picture summary about what we kind of know at the moment, or we're projecting at the moment, about long-term impacts of climate change on malaria. But even for that uncertain picture, there are some important caveats. The first one is this really crucial distinction between long-term trends and shorter-term variability. And a good way to think about this is just to look at the actual climate record for the last 100 years. So this is actual observed data. This is just global precipitation anomaly, so average precipitation by year for the last 100 years. And the black spiky line is the real data. And hopefully you can pick out the slightly faint green line that weaves within that, which is the smoothed decadal variation. So that's variation that's happening in a cyclical way on approximately 10 to 15-year timescales. And that includes things like the El Niño Southern Oscillation. So these are somewhat predictable climate cycles that the globe goes through that are 5, 10 to 15 years in duration. And then the red line is just the kind of long-term average trend. So the point I want to make here is that if you're a malaria control program looking ahead on, let's say, a 5-year planning cycle or 10 or 15-year longer-term sort of strategic planning cycle, and you're thinking about what's going to be the influence of weather and climate on the malaria situation that I'm going to be facing, overwhelmingly the variation that you face is not driven by this long-term trend. It's driven by almost stochastic year-to-year variation, and it's driven by these 5, 10, 15-year climate cycles, which are happening naturally anyway. So a place that's projected to become wetter over the next 100 years overall could very easily still be facing a 5, 10, or 15-year period in which they have a drier run of years than the average, or vice versa. So that interannual variability is still a crucial component that we need to consider. And one of the features of the climate projections is that the magnitude of that variability will increase. So as well as the long-term trends, we have a more variable and a more unpredictable climate to contend with. The projections also predict changes in the seasons, in the timing, the onset, the duration, and the intensity of seasonal cycles. Again, with really obvious kind of practical implications for year-to-year planning of seasonal interventions. And the projections are, there's a great deal of consensus that we're going to see an increase in frequency of extreme weather events. So that includes droughts, but also storms and flooding. And again, this is likely to have very obvious and immediate implications for malaria control. The other caveat is that, to my mind, it's entirely plausible that by far the most consequential impacts of climate change on malaria and malaria eradication could come from more sort of indirect effects rather than the changing climate itself. So it's conceivable that over the next 50 years and beyond, climate change will lead to an increase in instability in all sorts of different ways. So an increase in armed conflict as competition for resources increases, an increase in population displacement as areas become inhospitable and inhabitable, additional pressure on health systems, potentially waning international commitment for malaria control when faced with larger domestic challenges to contend with. So any or all of those potentially could combine to throw a banana skin in our path to eradication that is more consequential than the direct impacts of changing rainfall or changing temperature themselves. So faced with a potentially grave but poorly resolved and poorly understood threat, what are some of the practical actions and thought processes that we might be considering in order to make ourselves as robust as possible to these threats? And I kind of think of this in a couple of different time frames. So in terms of the kind of short-term operational response, for me that really needs to be focused around just ongoing improvement of our situational awareness, of our ability to understand what's happening kind of in real time on the ground in terms of malaria. So if we can identify emerging threats, changing patterns, changing seasons, via strengthened malaria surveillance systems that provide more robust, more granular, more timely monitoring information about both the disease but also the vectors, then of course we're going to be better able to mount effective responses. Now, of course, strengthened surveillance is a critical pillar of malaria eradication with or without climate change. But it may, for example, be that we need to add additional focus to those fringe areas which don't have much or any malaria at the moment, but where we want to be vigilant to detect changing epidemiology. Then there's kind of a medium-term operational planning time frame. I think increasing our technical ability to be able to forecast forthcoming seasons, what's the next 12 months potentially going to look like in terms of timing, onset, etc., of peak malaria seasons? Are those plans shifting geographically as well as temporally? If we can do that, then again, we can mount a more effective annual planning cycle, and the targeting of interventions that Perpetua's been talking about in HPHI, for example, can be refined with some foresight in terms of what the malaria season is going to look like coming down the track. What would the science need to be to facilitate that? Well, we do need to continue to refine our understanding of this link between near-term climate forecasting or weather forecasting, seasonal forecasting, and then what that means in terms of malaria. And we need to be able to do that in a way that's highly geographically specific and tailored to the local ecology. And then long-term, I think, again, more science is required at this interface between the climate science and the malaria epidemiology. can we begin to narrow down some of this broad uncertainty that still exists in terms of what are these long-term trajectories looking like? Can we narrow down these plausible scenarios in terms of changing malaria, extent, intensity, seasonality, epidemic risk, that we need to be thinking about and preparing for more as a global community over multi-decadal timescales? So on that note, I will conclude. Thank you very much.
Thank you so much to all our speakers. We covered a great range of topics. We have some time for some questions, and you can approach the mic if you'd like. And to the IT guys in the back, I've lost our internet connection, so I can't see any virtual questions coming through.
I'd like to thank all the speakers for a really excellent symposium. I have a question for Dr. Fornace. You really nicely laid out the situation with Plasmodium knowlesi in Southeast Asia, the increasing numbers in Malaysia, and the wide extent of transmission. And I'm just wondering what your thoughts are about what this says about the eradicability of malaria. Do we still think that it's feasible to eradicate a disease that has a zoonotic reservoir? Or do we have to start thinking about eradicating different species of malaria?
Yeah, thanks very much for the question. It's obviously something we've been thinking about a lot. I think it's challenging to think of how we can eradicate something with the wildlife reservoir, particularly when we don't have any interventions to treat the reservoir. So maybe it's a matter of thinking more and more about a species level and thinking about the types of surveillance and the types of control measures that are appropriate when we have this increased spillover risk. But I don't know if there's any other thoughts.
Hello, Ghislaine here. Dr. Perpetua, this question is for you. Thank you very much for this high-level summary of the HBHI process experience approach in Nigeria. Looking at it from a capacity building perspective, can you tell us a little more about some of the lessons learned there? What could be done differently, especially for other countries who are yet to go through the process? Thank you.
Okay, thank you for that question. So in terms of lessons learned, one of it is that you have to have that country dialogue. It's very critical when you want to introduce the HBHI. Make sure that all the partners are on board, and even to the policy makers and the government, the decision makers in terms of funding. You also have to make sure they are involved from the beginning so that everyone understands the implication of that, because for that first response element in terms of strengthening political will, they have to be involved, and you have to have their buy-in because they're going to have to increase funding for malaria, domestic resource mobilization. Beyond that, there have to be clear guidelines on how you're going to go about it. So you need WHO support to provide those guidelines for you. So because what we had, because we were one of the first countries to adopt this, so there was some initial confusion about where we were going to go in terms of those response elements. But luckily now more countries are already adopting that, and I think there are more guidelines available from WHO that would better help the country to, each of those response elements, what are you going to prioritize, particularly in terms of a resource-constrained environment. You want to be able to prioritize some package of interventions over others, or within those four response elements, which one is critical, which ones are the low-hanging fruit, for instance, that will help you to achieve quick impacts that you can measure. So you need to be able to have those guidelines and support so that you can prioritize interventions. And then the sub-national tailoring, the availability of good data is very important. So when you don't have that, you also have to see how you can gather all your local data with support, because without the good data, you are not going to be able to do the analysis that you need to determine what package of interventions that will work in certain parts of the country and what you would need to prioritize. Thank you.
Hi, thank you very much for the talks. My name is Tim Beard from Wellcome Sanger Institute. So my question again to Dr. Perpetua. It's great to see the major steps you've taken, but I didn't see much mention of genomic surveillance, and I wondered what you see as the role of genomic surveillance for driving decisions around targeted MDAs and SMCs within Nigeria.
Yeah, okay, yeah, thank you for that question as well. Yeah, we are also doing some genomic studies, particularly through our therapeutic efficacy studies to look at the nationally deployed ACTs that we're using. And we have data from that because it helps us to determine whether the ACTs that we're currently deploying, the first and second line ACTs are still as effective or whether we need to go beyond. Luckily, we also had recently revised our national guideline for diagnosis and treatment, so we have options as well. We are also doing genomic studies looking at surveillance in terms of, different, so we've done a genetic kind of mapping for the country. So using our national survey data, we're able to see how we are faring, not just for the ACTs, but also for other interventions, particularly for the ACTs and the SP. We did some resistance monitoring for the SP when we did the community IPTP. So we are also monitoring the SP resistance in the country and also ACT markers. So we are working on that as well.
Thanks for the session. It's Lucia Kell from Imperial College in the UK. I had a question for Pete about the climate talk. Thanks for that really nice overview. I was curious, in the Malaria Atlas project, I guess you have a lot of temperature and rainfall variables in there. Is that something you could pull out of the map model, what climate change scenarios could do to malaria prevalence? I know some of the previously published climate models, they don't always necessarily compare predictions against prevalence, for example, so it would be interesting to see.
Thank you, Lucy. It's a good point. I mean, we're well placed to do a kind of large-scale empirically driven study in that we've got about 80,000 observations of prevalence across the globe going back about 25 years. And then very, very detailed, I think certainly monthly, if not 10-day interval, satellite-derived rainfall, temperature, humidity, and all sorts of other things. So we do routinely learn the relationships between those environmental drivers and the parasite rate response as part of a large multivariate kind of approach that takes into account lots of other environmental factors as well. So in a way, we embed those relationships in our predictions. Now, but they're, as you know, they're designed mainly to predict the present and the past, as opposed to long way into the future. We did an exercise, in fact, in collaboration with Kim and others at WHO as part of the SAG-ME exercise, and also as part of the Lancet Commission on Malaria Eradication, where we did use that framework to project forward the map of malaria prevalence into 2030 and 2050, actually under some of those SSP scenarios that I talked about. And we came up with results that were, broadly qualitatively similar to those that were derived using the mechanistic malaria transmission models. Essentially, that where there's a very clear temperature signal, and that's the main factor driving the limits on malaria transmission, you see a very obvious response in the future in terms of worsening malaria situations. But everywhere else, it's so shrouded in uncertainty when it's rainfall that's the issue, both about what rainfall will look like in the future and how rainfall directly affects malaria transmission, that we were fairly inconclusive, as with everybody else. There's ongoing work at MAP, and I'm sure in many other groups as well, that's hoping to narrow down some of this uncertainty about these current relationships. we're doing this very, very large literature review of seasonality profiles. We've got about 4,000 seasonal time series that we extracted from the literature, which give that real granular information about the, how within-year variation in climate and weather feeds back into timing and intensity of malaria season. So yeah, watch this space. There's hopefully going to be some progress on elements of that question in the near future.
Hi, thank you. Thank you to all the panelists. I'm Molly Robertson from the Global Fund. And in formulating this question, I was really thinking, well, perhaps this actually is a question for myself. But in thinking about both Peter's talk about the situational awareness that we need, and then Dr. Perpetua, your great review of all of the ways that data review has really informed your decision making, what are some of the ways that we can support a more flexible system in terms of both the information that we have and the response, given the climate emergencies that happen, given some of the resilience that we need in our system, both in terms of the climate emergencies themselves, but also what kind of other emergencies come about because of that kind of climate change situation. Thank you.
I will hand over to Perpetua because she deals with these kind of enormous challenges on a day-to-day basis in the real world, whereas I sometimes look at them on computers in a lab. I think from the sort of science and technical side, we can contribute to this better response, better foresight by doing some of this basic science that still needs to be done in terms of, okay, if we have a decent weather forecast, we know something's coming on a monthly or annual basis, we can provide to programs better granularity about a forecast of what we think the malaria season is going to look like this year, how it was different from last year, how its timing may differ, how its geographical focus may differ, and that may help. But then, of course, the hard work has to be done by the programs themselves. So.
Yeah, thank you. Actually, we already use those rainfall forecast, weather forecast data for our SMC implementation. So at the beginning of each round, we have to do that. We get those information from the meteorological agency in the country, because that gives us the prediction for the year when the rainfalls will start in different parts of the country, and that determines when we are going to start our SMC implementation. But also it's very important, just like you mentioned, in terms of disaster response and emergency preparedness. Using those kind of forecasts, one can also, use it to update the emergency preparedness response, which I would assume that every country would have. So, for instance, now the country, Nigeria, is experiencing a lot of flooding, and, so the program and the country is trying to respond to that. But if you already have like a well-defined emergency preparedness plan, it will help. But of course, getting this updated information from the relevant agency on what the predictions will be, that will also help you to better prepare. I don't know if I answered your question. I didn't quite get it. Did I answer your question, Molly? Thank you.
Okay, thank you very much. My question is to Professor Shanks. You delved so much on the role of 8-aminoquinones on MDA. My question is, what about their role in routine treatment, and of course considering the.
Sorry, could you repeat it? We've got an echo up here. I couldn't hear the last part.
Oh, sorry. I'm saying, what is your comment on the role of 8-aminoquinones on routine treatment for as combination therapy for PF, considering the huge burden of asymptomatic infections that may also transmit? Thank you.
All right. I think there is a role, but that's not in any way to degrade using ACTs to treat falciparum malaria. I think the role may be for the asymptomatic parasitemic person and trying to clear blood stages. We know in our challenge model done at QIMR that 100 milligrams of Phenoquin by itself will not clear a falciparum challenge, but 400 will. And anything in between if it's metabolized, will tell you when it's going to recrudesce. So it will take out falciparum malaria if it's metabolized. And I think the same combination that I was promoting, if you will, there, will take out falciparum malaria at low parasitemias. That being said, please don't let anybody in this room say that I'm suggesting that we use it as a single treatment for falciparum malaria. ACTs really do work, really should be used, but to kill the last parasite, to eliminate it from a population, it will certainly take out falciparum. It will take out all four. Actually, it'll take out monkey malaria.
Yeah. My thinking was, in addition to the current ACTs, we add it as part of the triple therapy. We had the. What about that? Adding
transmission blocking.
Yes.
Yes, it blocks transmission too.
So don't you think that is maybe a better strategy rather than just waiting to use them in MDAs, for instance?
Again, I think MDA is the way we're going to have to go, because a lot of these people are simply not going to be sick. They're not going to front up at the clinic. We're going to have to go out and kill the last parasite. That's what elimination means.
Thank you.
So I congratulate all the speakers for the excellent presentations. I have a question for Dennis. Dennis, thank you for highlighting the need of 8-aminoquinolines in the eradication of malaria. There is an interesting data you mentioned about the acceleration of Phenoquin metabolism by chloroquine. So what can be the potential mechanism for that, and do you think that it may lead to higher hemolytic toxicity also?
Well, it's a great question. There's at least two options, and we don't know which one yet. Chloroquine induces the aryl hydrocarbon receptor, and it may be an induction of cytochromes through that, or it may be something else that's driving the metabolism. But it's very remarkable, and it's very quick. So I think it's what we've been seeing all along for the last 100 years, that if you combine your schizontocide, which we know has no effect whatever on the hypnozoite, with your 8-aminoquinolone going all the way back to Pamoquin, they work much, much better. And I think it's just not the schizontocide itself. I think it's working through the 8-aminoquinolone.
Okay, thank you so much, everyone. And thank you, everyone, for staying in attendance. It was a wonderful symposium, and see you next year.